Well, thank you. Once again, welcome everybody. Let me just run through a few simple highlights from Gail's earlier comments about what AOF is about. We have some overview policy objectives that we pursue together. They are, first of all, a strong belief shared by all of our participants, those on the steering committee and those who endorse us statewide, that a strong belief that Ohioans, all Ohioans, should have the opportunity to participate in the economy, to be able to obtain the basic things that they need in life, and through all of that, to pursue a higher quality of life. As Gail mentioned, we place a heavy emphasis on eliminating poverty and the effects of poverty. We believe very strongly that those who work should be able, through their work, to lift themselves out of poverty. And that is a very ambitious goal, particularly in the challenging economy that we're in, which, as Gail's earlier comments and charts showed, it doesn't work that way. That work alone is not enough to get folks out of poverty. And in fact, as she highlighted, we have a decline in wages and median income while we have an increase in the cost of things. Let me jump in very quickly to the lead issues that AOF is working on. We go through a process to decide these, but the bottom line is that the 4 areas that we've decided to work on this year include, first of all, a person-centered work program. This would be a program that would allow for in-depth assessment of people in the Ohio Works First and food assistance programs to determine their strengths as well as the barriers to their being able to pursue a higher level of economic stability through employment, and how those barriers can be addressed. We also are supporting work support programs, those programs that support people while they are working. For example, child care assistance, the Earned Income Tax Credit, Medicaid, food assistance. And we are focusing specifically on 2 that where the state legislature and state funding can make a difference to increase child care eligibility and to make a state Earned Income Tax Credit refundable like the federal credit so that people can receive more money back when they're working. The third lead issue is improvements in the direct service workforce in the state. These are people who care for our loved ones in both in institutional settings and in home settings. The objectives here are to increase their pay. They work for very low pay and are themselves eligible for all kinds of assistance programs, as well as to improve their conditions and improve the care that their clients are getting. And finally, in the adult protective services arena, to ensure the safety of older Ohioans through some kind of substantial funding base through county agencies that would enable them to provide meaningful assistance to older Ohioans in their areas consistently over time. There's been an incredibly modest amount of funding for a long time for adult protective services. We would like to see that increased. There is, in addition to our lead issues, we have several partner issues. These are issues that we identify that are very important, but there are issues where other agencies or entities can take the leadership and have taken the leadership over time so that AOF doesn't need to exercise that kind of leadership here, but rather plays more of a support role by partnering with them and supporting the things that they identify as needing to be done. For example, under food assistance, increasing food banks funding, with the Food Banks Association taking the lead. Children's Services desperately needs increased funding, and Public Children's Services Association takes the lead there. Medicaid, maintaining Medicaid eligibility, which basically means maintaining, among other things, the eligibility that was established 2 years ago through the expansion, and to oppose cuts and so-called reforms in the Medicaid program that, in fact, make it more difficult for people who are eligible to obtain and maintain coverage. In the arena of mental and behavioral health, to increase funding and to support the integration of mental and behavioral health into the managed care arena, and I'm sure Teresa will have a lot to say about that. And finally, in the area of housing, to support Ohio in its efforts to create a reserve fund in the Housing Trust Fund. let me say that our partner status means basically that AOF responds to requests for help from partner organizations in these identified areas. Aside from our lead, and if you go to the next slide, lead and support issues, we will respond to requests for help, for support, for any number of other issues. We have a very strong commitment to a strong broad-based human services system, so it's not just the issues that I've identified where we lead or partner that we can do meaningful activities on, and I've provided a couple of examples here that if people ask AOF for assistance on something, we can do those things through things like sign-on letters of support or communications with and through our grassroots network that can provide very meaningful help. Our approach to showing solidarity is actually pretty cool. People who address our lead issues include language that indicates that we're not only supporting our lead issues, but that we need investments that benefit all Ohioans, and therefore that we support other issues besides those lead issues. And all of us, for example, and I'll say a little more about our testimony in a minute, who testified last week made that clear. At the same time, AOF partner organizations that address partner issues before the legislature are utilizing language in their testimony that indicates that they are participating in AOF and that they support other AOF issues as well as enjoy the support of AOF for their issues. So there is, through this kind of working together and agreements on using language, we're communicating a consistent message to the legislature that we're all in this together. Now, the budget process, I will zip through this pretty quick here. I think people probably know most of this pretty well. The governor introduced his budget early in February, and House Bill 64 incorporates that budget plan, and it's been introduced by Representative Ryan Smith, who's the chair of the Finance Committee. The administration officials in the early weeks presented their presentations to the Finance Committee, and for the last few weeks we've been preparing, working with the subcommittees of the House Finance Committee in order to pursue our issues in different areas. And we've worked pretty much exclusively with the Subcommittee on Health and Human Services of House Finance. We had a panel of AOF leaders who presented our lead issues last week on the 11th. It seemed to be well received by the subcommittee. There were a good number of questions and seemingly a lot of interest in a number of our issues. Others, particularly our partners, have also presented both last week and this week, yesterday, at another hearing before that subcommittee on issues that their issues that happened also to fall in our orbit. There is ongoing budget work. AOF leaders, members of our steering committee, members of our policy committee are having meetings with various finance subcommittee members and other legislative leaders to go through our lead issues, present them in more detail than sometimes we can during testimony. I think it's just to touch on these very quickly and lightly. The administration has proposed its own intensive case management person-centered work program, and we're very interested in that and generally supportive with some strong cautions that there needs to be a realistic timetable, needs to be realistic funding, and a realistic plan. The administration has proposed some child care eligibility increases. We'd like to see those changed a little bit. We'd like to see a higher entry-level eligibility for child care, not quite as much emphasis on the exit level, and we're, I think, getting some traction with some legislators on that. In the arena of Adult Protective Services, or APS, there is the passage, once again, of legislation in the House that does some policy changes, but we need additional money in the budget, and it's not clear where that it rests at the moment. Finally, with respect to the direct service not case managers, but direct service workers, there are proposed increases in reimbursement rates, as well as system reforms and training in the administration proposal. And there's quite a bit of work going on behind the scenes on that. So to say in summary fashion that there's a lot of work going on with the legislature around these issues, as well as everybody can imagine, the partner issues and others that I referenced earlier. Let me say just a word or two about days of action. We've had two, on the 10th last week and on the 17th this week, where we have supported organizations in making calls on various issues. Last week on Medicaid eligibility cutbacks, this week on increased food bank funding. We believe these are very important and useful strategies for involving members of our supporting organizations like you all around the state and participating in this advocacy to support these important issues. And lastly, just a note that we have an active policy committee. It helped identify and help determine our policy, our priority issues. We are constantly involved in analyzing the situation in the legislature and making adaptations to dealing with it, and are meeting weekly to determine, share intelligence and determine our plans. So, in a word, and I'll finish with this, the coalition is very, very actively involved at this point in the legislative process. I'll stop now and turn it over to Kate.
Okay, well, good afternoon. This is Teresa Lample with the Ohio Council of Behavioral Health and Family Services Providers. And for those of you who aren't familiar with our organization, we are a statewide advocacy and trade organization that represents about 150 community behavioral health, addiction, treatment and prevention, and family service providers across the state. And our members serve over 600,000 Ohioans annually in the delivery of services that they need to meet their behavioral health conditions. So I'm going to talk a little bit about the behavioral health benefit. I'm going to kind of start with Medicaid and then end with Medicaid, but really wanted to spend a moment to talk about the value and importance of the expanded Medicaid eligibility in terms of providing access to treatment services. We knew going into the conversation in the budget 2 years ago around expanding Medicaid eligibility that this was something that was critically necessary for people who had behavioral health needs, particularly substance use disorder conditions. And as we've expanded access to Medicaid for low-income Ohioans based on their income, we have seen the results of that in that more than 60,000 people were able to access behavioral health services this calendar year than previously. And of that, we know that 17,000 access those services for the first time. So that's a very substantial number, and the vast majority of those folks who sought treatment were single adults, and many of whom were struggling with an addiction issue. The estimated savings that was created through being able to use Medicaid resources was $58.7 million annually, which means that's the amount of money that should be available locally for reinvestment in services that support people in their wellness and in their recovery. So in looking at the budget related to behavioral health services, there's several things we wanted to point out. One is that the administration's proposal, particularly in the mental health and addiction services section of the budget, continues an approach of targeted investments to address gaps in the service continuum. It proposes expanding the array of services that are available, which is something that we have personally been advocating for a number of years. It proposes improving care coordination by transitioning to a managed care model, which we'll talk about in a little more detail. And it proposes doing those last two things in a manner that is budget neutral, and it gives the administration broad flexibility in how to move forward with making these types of changes. So there's limited legislative oversight or accountability, which really means that when you actually read the budget bill itself, it's very hard to find any detail around what are the proposed changes or the expectations. You have to really look at the documents that the Office of Health Transformation has put forward, which provide a very general framework in terms of what to expect. So we'll start with the targeted investments because I think there's some very interesting things in the budget that will go a long way. The first thing I wanted to point to was that there's an investment in the Department of Mental Health and Addiction Services and Corrections, or the Department of Rehabilitation and Corrections partnering. And what this will do is bring the Department of Mental Health and Addiction Services will essentially assume control for providing behavioral health services inside state correctional facilities. And the goal of this is to then, the staff will then become employees of the Department of Mental Health and Addiction Services, which will hopefully create some alignment with the services that are provided through the state psychiatric hospitals. And the goal is also then to expand staffing specifically to provide addiction treatment. And when you look at the 50,000 or so people who are in the state correctional facilities at any given time, about 80% of them have a history of addiction. Yet only about 15% receive treatment while they're actually incarcerated. And when you look at recidivism rates, those that have received addiction treatment while they're in the prison system actually do a better job of not returning to prison. So we think that's really important. And then the other piece is that there's money allocated to invest in behavioral health services that do two things, that support diversion. So it prevents people from actually coming into the prison system, and then more importantly on the backside, if they've been in the prison system, that there is increased investment to build services to support people when they come back into the community so that they can be successful and maintain their recovery. There's also money in the Mental Health and Addiction Services budget that will continue to support court programs, both to continue and expand the drug court pilots that have been in operation since in this last biennium. It also increases funding to support specialty dockets, so both mental health courts, drug courts, family courts, veterans courts. There's a number of specialty dockets that have been formed around populations and then specific disease conditions, whether it's mental health or addiction issues. There's also some money to provide additional support for forensic services or forensic evaluation, and then probate courts, both related to funding for indigent defense, as well as some money may be available to help people understand assisted outpatient treatment. Another bucket of targeted investment is related to community and hospital partnerships. So it's really looking at what are the resources around state psychiatric hospitals and with local community providers, and how can we better support local law enforcement, because what we find is that the local jails and prisons have become largely filled with people who may be experiencing mental health or addiction issues, and how can we support those folks in getting the services that they need and returning to community rather than remaining in jail or moving on to a state prison. There's also an increase in an allocation to support state psychiatric hospitals. As we've increased access to services, we've also seen an increase in capacity or need for state psychiatric hospitals. So this is money that's allocated to deal with the cost of increased demand. There's a continuation of additional investment in housing and employment, so continuing to support residential state supplement, which is a source of money that helps support people who have disabilities, particularly mental health conditions, in maintaining community-based residency. Recovery housing is a new concept that is really trying to create an opportunity for people who have begun to recover from addiction and having a housing option for them that is substance-free. And then there's an employment investment to create incentives for employers to help them consider employing people who are in recovery, particularly those who are in recovery from a drug addiction. We were very pleased to see that there's a continuation in investment in the prevention arena. Certainly this is an area where we need to do more, and if we can catch things early, have a better opportunity of reducing not just long-term spending, but helping people be healthier earlier on. So there's a continued investment in terms of targeting at-risk families and communities where there may be specific needs that a community has, that they can make a one-time investment that will go a long way to building the supports to keep kids at home, to keep them safe, to keep their families safe, and so that their kids can grow and be, healthy, do well in school, and grow up to be, strong and healthy adults. there is a new investment of $5 million to support early childhood mental health consultation. So this is really working with at-risk families at the very young age to help them move forward in growing up and having parents that can parent children who may be at risk and hopefully help them be ready to go to kindergarten and ready to learn and achieve. An investment of money towards working with at-risk kids who have incarcerated parents, because statistics show if you have parents who are involved in the criminal justice system, it increases the likelihood that those children could end up having that same pathway. Suicide prevention, there's a new initial investment, and then investment in providing access to naloxone, which can be used to help someone who is in the midst of an overdose to prevent them from dying. And then a continued investment, it's a small investment, but continuing to support efforts to understand what does it mean to provide trauma-informed care, which is really understanding that many of us have faced trauma at some point in our lives or experienced toxic stress, largely due to poverty, and what does that mean in terms of lifelong trajectory for health and wellness. In terms of expanding the behavioral health services, we're really looking at how can we redesign the services. They have identified an array of services which are listed here on the slide that they would like to see added. Many of these services focus on providing the types of intensive treatment that people with very intensive needs have. And so the challenge that we have is how do we add these additional services to support people in need of very deep-end services while maintaining access to services earlier in a disease process so that people don't have to become sick before they can access care. The other piece of the expanding the services is really looking at how we deliver care so that it's aligned with the physical health care delivery system so we can achieve better integration. In terms of continuing to support integration, there is a proposal to transition the behavioral health benefit into some form of managed care. There is just a beginning of a conversation to look at what those models might be and how that might move forward. To say that I think that from our perspective, it really is you have to start with the services and the array of things that are available and then figure out how do we best support that transition so that we're doing a good job of integrating care, that people have access to the right type of care and the right type of providers to meet their needs. And at this point, what the administration said is the timeline for that is somewhere towards the end of state fiscal year 17. So summing it up, we know that Medicaid is critical. It has brought about $58 million in resources to the state that allows other state and local resources to be invested. We know that the mental health and addiction service proposal includes about $48.6 million in targeted new investments, and that's a total investment of about $106 million annually, which is very substantial if you understand the way that services have been cut previously, particularly through the most recent recession. And then our ask is that if the administration would choose to, or the legislature would choose to allocate additional money, that go into the continuum of care line item in the mental health and addiction services budget, and that with rebuilding the behavioral health service capacity, that we're looking for temporary language that provides some oversight and accountability and timelines related to how the services look and as we transition into managed care so that we maintain services and capacity and rebuild the infrastructure to maintain the workforce. With that, I will turn it back over to Kathy.
Thank you, Teresa. Can everybody hear me? I hope so. Okay, I'm jumping back to my presentation. There I am. So I'm Kathy Levine, Executive Director of UCAN Ohio, a statewide nonprofit organization working for healthcare for all. And I'm going to give an update on Medicaid and healthcare in the state budget, mostly Medicaid. And I just want to say I'm so honored to be on the steering committee of Advocates for Ohio's Future with a group of real experts, as you heard Teresa and Carl talk. As a coalition, AOF can really dive deep and find meaningful solutions to problems related to poverty in Ohio. And with that, let's jump into the Medicaid budget. The proposed budget, the budget proposed by the governor, retains the current Medicaid program, including eligibility for all adults up to 138% of federal poverty level. We're not talking anymore in the context of the current budget about Medicaid expansion. Expansion is something that happened 2 years ago, and the Medicaid program is in the budget as is. And knock on Formica, but we have not heard of any serious talk about yanking that out of the budget. They'd have to make substantial changes to the budget. The budget also requires premium payments for childless, non-pregnant adults over poverty level, eliminates special coverage programs for adults above 138% of poverty, eliminates independent providers from filing Medicaid claims, and has a projected savings of $100 million, which is $47 million state share over 2 years. And I've given you the link to the white papers on the Ohio Health Transformation website. The white papers are in plain English and describe initiatives, some of which are in the actual language of the bill and some of which are just things that the administration plans to do. Now, I'm going to be talking about Medicaid, which means you have to know poverty level, and so I've given you the poverty level chart to look back on. And the first item, as I mentioned, is what we're calling reauthorization of Medicaid, and all that if the budget is passed as is, then the so-called Medicaid expansion is reauthorized. And this has been a tremendous victory, as Teresa alluded to, in terms of the new investments in behavioral health. We have close to 500,000 newly eligible Ohioans covered since January 1st of 2014, 500,000, with another at least 200,000 who've come on who were previously eligible but have signed up now because of the outreach. And then we have another 234,000 Ohioans who have enrolled in the healthcare marketplace. Under the Affordable Care Act, they've enrolled in private insurance with subsidies because their incomes are above 138% of federal poverty level. So we have, in the last 2 years, reached close to almost 1 million people getting coverage. In the bad news department, the administration proposed to impose a monthly premium for people on Medicaid above 100% of poverty, so the people between 100 and 138% of federal poverty level. And 138% of poverty level is around $33,500 for a family of 4. So we're talking about people who are really struggling to make ends meet. The monthly premium for people above poverty level applies only to non-pregnant adults without children living in their household. And there'll be a specific amount of the premium will be calculated using the federal marketplace calculations, and it'll be capped at 2% of income. So they're estimating the average premium would be around $20 a month, and with 3 consecutive months of non-payment, an individual may experience a disruption in coverage. This will not apply to people on the Medicaid buy-in program for workers with disabilities or people getting long-term services and supports. In terms of, we are very concerned about the impact of these proposed premiums because there's ample literature for years and decades that even small premiums or other cost sharing causes people to drop coverage until they get sick. And it disrupts care management for people with chronic conditions. It causes people to, instead of getting prevention and regular care, to just seek crisis care. It also destabilizes healthcare financing. You know, the managed care plans get paid an amount per month, and all of a sudden they lose people. They can't do care coordination. Providers lose their patients, you know, when they go off and on coverage. The reason the administration did this was because the legislature was talking a lot about teaching people personal responsibility. And our response to that is that people with low incomes are achieving personal responsibility by paying rent, paying utilities, going to work. And what people really need, low-income people really need to do in terms of health care is to learn how to manage their health care when they have regular coverage. The budget also contains initiatives to reduce infant mortality. These are described in a white paper on the link that I gave you before, and the initiatives include enhanced care management for women of childbearing age, community health workers in very high-risk communities for all women of childbearing age, and reducing tobacco use. In addition to these are new programs programs that have existed in pockets around Ohio that have proven effective in small pockets. The administration is working with the managed care plans to expand these programs so that we can reduce Ohio's terrible infant mortality rate. We're near the bottom of all states, and when it comes to disparities with communities of color, we are at the bottom. Unfortunately, the administration proposed to cut eligibility for Medicaid for programs that go up to special programs that provide eligibility up to 200% of federal poverty level. They want to bring those programs down to 138% of federal poverty level to kind of standardize eligibility. The programs involved include Medicaid for pregnant women up to 200% of poverty, a family planning program that just provides family planning services for women and men, and the Breast and Cervical Cancer Project. And I'll talk about what the problem is with the administration's proposals. In terms of the cut to Medicaid for pregnant women, it appears that the administration expected that women above 138% of poverty would go to the marketplace and get coverage. And the problem with that is that if a woman is uninsured and finds herself pregnant, she cannot sign up at the marketplace except during a very brief open enrollment period, which is a couple of months at the end of the year, and she'd be eligible on January 1st of next year. And also there are women whose husbands have employer coverage, and they are not allowed to get subsidies on the exchange because they could get coverage at full price, without employer contribution, meaning that it's unaffordable. That's called the family glitch, and it applies to women whose spouse has employer coverage that's also available for the family, even if the employer doesn't subsidize the family premium. Coverage without any kind of subsidy or without employer contribution is prohibitively expensive for families below 200% of poverty. So there are a number of reasons why women who become pregnant can't get coverage at the exchange. And the administration also cuts the family planning program down to 138% of federal poverty level. And both of these proposals undermine the administration's laudable efforts to reduce Ohio's infant mortality rate. The family planning program allows an uninsured family to get family planning services even though they can't get full Medicaid coverage because they're over 138% of federal poverty level. While it would be preferable for them to have full insurance, if they haven't signed up for full insurance and they're seeking family planning services, this is available to them. And family planning services are a key infant mortality reduction strategy because they encourage families to space pregnancy safely. Safe spacing of pregnancies is associated with better birth outcomes, meaning avoiding low birth weight babies with complications and infant mortality. The other proposal is to cut the breast and cervical cancer project. So women up to 138% of poverty would be on Medicaid. For women above that, they'd be, again, have to go to the exchange, but if they're uninsured and get a diagnosis, they can't get onto the exchange. Getting a diagnosis of a disease does not qualify you for a special enrollment period outside of the open enrollment period. So that's about the cuts. Advocates and Ohio Consumers for Health Coverage, Consumer Coalition have done a lot of call-in days. Other providers are very much against this, and we'll see what happens in the budget. We're hearing some hope that something will be done about the at least the pregnant woman part, but we'd like to see all these services restored. Next, the budget eliminates independent providers of home care services, and this affects older adults, people with disabilities, and people with developmental disabilities, both children and adults, and anybody enrolled in My Care Ohio. People who need long-term services and supports to stay in their homes have two ways of getting them. One is they can ask an agency to send somebody, and the other is that they can find an independent provider. And many individuals prefer independent providers, more so in the under 60 category, because independent providers generally are paid more. You're picking an individual who's coming into your home and helping you with very intimate services. And, most states allow individuals to choose where and how they get their services. This is called consumer self-direction. Ohio has been having independent providers available as Medicaid providers, who submit claims like any other provider. Unfortunately, there are legal issues with how Ohio is doing that, so they have to change the way they make independent providers available. What they need to do is to expand and simplify consumer self-direction and guarantee a fair wage for the direct care workforce, so that people have access to decently paid independent providers. This has caused a big furor at the State House. A lot of people using independent providers have been speaking out. And the fix is not simple, and we're waiting for the state to be willing to sit down with stakeholder groups to talk about fixing the problem by making consumer-directed option available so that people can continue to use independent providers. I think the lawmakers recognize that they've got to do something about, and we're asking them to pull the administration's language, which just unplugs the IPs as Medicaid providers, but doesn't create an alternative. And finally, Medicaid eligibility for individuals with disabilities is being changed this year. The state is going to unify the disability determination systems of Medicaid. We are now a spend-down state, and we will no longer be a spend-down state or a 209B state if this goes through. There'll be one disability determination instead of two. Excuse me. The income standard for Medicaid eligibility will go up from 64% to 75% of the federal poverty level to match eligibility for SSI. The asset test will be raised, and an estimated 7,100 additional people will qualify for Medicaid, and spend-down will be eliminated, which is a nightmare for people who are on it. People above 75% of federal poverty level, up to 138%, can just go on regular Medicaid. There are around 4,500 people who are now on spend-down who will be above income for Medicaid. Most of them have mental illness, and we understand there's going to be a special program created for people with serious mental illness. and nobody knows who the other 1,000 people are. Kind of scary. So here's more information, and I'll turn it over to Gail.
Thanks so much, Kathy. And,
can I just answer a question? Is birth considered a life event? Yes. Childbirth is a special enrollment period, so somebody can sign on to the marketplace at childbirth.
Right.
But pregnancy is not, so you won't be able to get prenatal care.
All right. Thank you so much to our speakers for this detailed and pretty plain language explanation. There's so much that goes on in this budget bill, and I really appreciate your attention to detail on this to help us understand all the pieces that are moving right now. I want to give you all an opportunity to get involved in this advocacy work. So as you've heard from Carl and Teresa and Kathy today, there are so many parts moving in this budget, and one of the things that we do that's unique in Ohio at Advocates for Ohio's Future is to be able to be a voice for this range of services that are impacting people, especially people in poverty, and how they work together to help make our families and our communities stronger. So we hope that you will be joining us in advocacy going forward. Here are a couple of ways that you can do that. Frequently, and we've just started in the last couple of weeks, sending out what we call our Act Now emails. They're emails that have a specific advocacy request in them. Often it's to make a phone call to a legislator, or to send an email, or to make your voice heard on one of these many important and interlocking issues. As you participate in those, we know that especially your call and adding your voice to this conversation is so critical. We hear from legislators' offices that they've received these calls. We hear that they recognize the concerns, and it makes a big difference in their willingness many times to engage and to think critically about how to put together great public policy in Ohio. So we hope that you'll continue to work with us on those, and thank you to those who have been making calls and have been helping us move these issues along. It makes a huge difference. If you're involved on social media, we're active on Twitter and on Facebook, and we put our action alerts and our information out there every single day. So those links in front of you are live, and if you want to click on them and start following us and help to get that information out to your networks, you can help amplify that opportunity to be involved in advocacy in Ohio. We have one specific call to action that we're going to invite you to be involved in today, and you'll actually get this in an email following the webinar. So we are, this week, working with the Ohio Association of Food Banks to elevate their ask to fund programs that are feeding millions of Ohioans every year and helping them to deal with food insecurity and hunger. So we're going to be asking you to make 2 calls to legislators, and I hope that you'll take advantage of that in your email so you can start being an advocate today with us.
Gail, can I make one follow-up comment to what you just said? This is Cole. I just want to underscore why it's so important for those of you around the state to be making these calls. Legislators hear from folks like us, and when I say us, I mean those of us who are in and around the State House a lot and who know them, have relationships with them, and they're quite accustomed to hearing from us, but we're not their constituents most of the time. When they start hearing about issues from their constituents, people from their own communities, it makes a huge difference. You may find that not entirely believable, but we can assure you it makes a big, big difference for virtually all of them if they start hearing from people in their community, people that they may know or they may know of, or at least that live there and can vote for them or not. So that makes it incredibly important that our network around the state be mobilized in an effective way to speak to these